Great to see so many people join the call. Thank you ever so much for being here with us this afternoon. Welcome to the Community Mental Health and Wellbeing Transformation webinar, which will be focusing on the Personality and Complex Trauma Service, which you may have heard referred to as PACT. My name is Eloise Thompson. I'm Community Mental Health Transformation Programme Manager, and I'll be chairing the session today. I'll just start by running through some housekeeping. So if everybody could please ensure that their cameras are turned off as we're listening to the presenters, just so that we can focus on them and the slides that they're presenting. You'll hopefully all already be muted, but if you're not, if you wouldn't mind just putting your mute button on, that would be great. We're expecting the session to last about 50 minutes, so that's normally about 30 to 40 minutes of presentations, and then there'll be time at the end to ask questions and have a bit of reflection time. If there is anything that you wish to ask during the session, or anything that you wish to provide any thoughts on, if you don't mind doing that in the chat, if there is anything that we're able to answer, we will do as we go along, or we'll make sure we bring that back in at the end of the session. We will be recording the session, so if anybody's got any objections or any queries that they've got around that recording, Janine will pop her email address in the chat box as well, so people can contact her directly just to query about that. And then we will of course be sharing the slides to everybody attending after the session. So today we will be having a session on supporting recovery with the Personality and Complex Trauma Mental Health team. So you'll be hearing from our colleagues Elle and Jude. And what, I don't know if you're there, Elle and Jude. I just don't know if you're there, just to...
Yeah.
Excellent. Sorry, I couldn't see you. There's pages and pages of people. Just checking you are actually there. Okie dokie. So I think if it's okay, guys, if you're both there and ready, I'll hand over to you both to introduce yourselves and take us through the session.
That's lovely. Thank you. So I'm Elle Cheel. I'm the team coordinator for the Personality and Complex Trauma team.
And I'm Jude Snowlam. I'm the lead occupational therapist in the Personality and Complex Trauma team.
So I believe we don't have to share the slides. I believe Janine's doing that for us. Fabulous. Thanks, Janine. So there you go, our names in lights. We've co-produced the slides for today with our peer support workers, Laura and Martha as well, because we have a strong belief that things should be co-produced within our team. I keep moving my face between two screens, so if I look this way, I'm not ignoring people. I've got two things going on at the same time. So next slide, please. So this is who makes up PACT. So we were founded in 2020. We're a multidisciplinary team and we're available on Mondays to Fridays, 9 a.m. till 5 p.m. We've built some strong foundations over the past 5 years as part of the transformation of mental health services here in Lincolnshire. And we cover the whole county of Lincolnshire and work closely with other teams within LPFT and our partner agencies outside of the trust. We don't have any magic powers and we don't have all the answers, but what we do hold is the patients at the heart of our service. And our experts by experience are at the core of our design. Each element of our service and delivery has been considered and planned from a patient's perspective up. Next slide, please. Excuse me. So the cause of personality difficulties are complex and multifaceted, involving a combination of biological, psychological and social factors, drawing from both internal resources and the trusted external resources. So a clear and simple explanation would be that there's genetics involved as well as biology, early life experiences and childhood trauma, verbal emotional abuse, high emotions or high emotional sensitivity, social and environmental influences. And we thought about today's slide, and we thought we could have given you a slide full of statistics. Please don't ask for them. We've not got them. And so we thought about how we support the people, and we wanted to talk about what's at the heart of us. We take pride in being our authentic self. So trying to understand this, we're going to think about a case study. So I'm going to hand over to Jude. Next slide, please.
So meet Elizabeth. Elizabeth has a diagnosis of EUPD/BPD/PD, whichever one you are that comes up. So just take a couple of seconds just to think about what you think and what you see and what you feel when when you're now meeting Elizabeth and hearing of her diagnosis. Do you think there's somebody who's angry, demanding, causing you stress, a time waster, a manipulator, an attention seeker? Do you feel afraid? Do you think you don't have the skills to manage what's in front of you? Are you worried you're going to say the wrong thing and make things worse? Next slide, please.
Let's press pause. Let's take a deep breath and count to 5. Now, let's start again. Let's meet Elizabeth. Next slide, please.
Meet Elizabeth again. Elizabeth grew up in a chaotic family home. She was often cared for by her grandmother, who sadly died when she was 5 years old. Elizabeth and her brother would hide under the bed to escape the violent arguments from their parents' room. From an early age, Elizabeth was exposed to intense, uncomfortable emotions without being able to understand them. Next slide, please. At school, Elizabeth was bullied by other children and didn't know how to fit in. She reached out for support but was not believed. She found some solace in her local library, where she'd go to escape the arguments at home, which sparked her love of books as an escapism. She met an older man who showed her the care and safety, the elements that were missing from her life. Quickly, this relationship became abusive. Elizabeth began to hate and blame herself for this relationship. Elizabeth began to self-harm as a way of coping with this relationship, along with the other stresses at home. Next slide, please. Now we see Elizabeth as a 22-year-old. Elizabeth has an internal dialogue of being a failure, worthless, ugly, with no future. Her self-harming has escalated, and she is often found standing on bridges with thoughts to end her life. Elizabeth has been detained under the Mental Health Act 3 times and also admitted to a mental health ward. She has regular contact with emergency services, crisis team, but doesn't engage and tends to walk away. Her housing is unstable. Neighbours are complaining because the emergency service is always being at her door. She started to access services but has disengaged and is now barred from accessing community groups due to the fact that she's carrying around razor blades to harm herself. Each time she attempts to work, she struggles with her colleagues and ends up walking out and leaving the job. Following her last admission, the community mental health team approached PACT for a consultation. Next slide, please.
Elizabeth's journey with PACT has started. The PACT formulation is our first step. So this is where we look at what's happened to someone. So we think about Elizabeth's background and her experiences. We think about what she's learnt from this and how people who should care for her haven't. People who should keep her safe haven't been able to. So we think about how they've learnt to survive, what coping strategies Elizabeth has developed. We think about when they need to use these survival strategies. So when their when their attachment style comes at play, we might see that she needs to escape the situation she's in, or she may inwardly turn this into self-harming. We think about what happens when they use the survival strategies. So what reinforces that? What keeps them using, or what keeps Elizabeth using these survival strategies? We think about her strengths, her love of books, the way she's been able to survive to today. And then we think about what it's going to be like taking part in treatment. This helps us get a deeper understanding of Elizabeth's needs, and what will help her and empower her into a healthier and more fulfilling life and a life worth living. This deeper understanding helps guide us into which pathway with PACT would best meet her needs, along with using our therapeutic stance. Next slide, please. So our team's strong foundations are built on a shared therapeutic stance, which is in front of you now. We remain hopeful that things can change, even when the individual isn't able to see that for themselves. We work hard at doing what we say we will do. We don't always get it right, but we will always repair any ruptures and try again and again and again, and however many times it takes. So we're going to look at what pathways we do offer in the next slide, please.
Sorry. So there are three main pathways in PACT, and then we also have peer support, deprescribing and psychology alongside these pathways. So the first one is dialectical behavioural therapy, or shortened to DBT. So dialectical behavioural therapy is a structured, evidence-based therapy that combines cognitive behavioural techniques with mindfulness to help individuals manage intense emotions, reduce risk to self, and improve relationships. Moving on, we have structured clinical management, again, 3 letters, SCM. Structured clinical management is a time-limited, evidence-based therapy designed to support individuals with personality difficulties by providing clear structure, emotional validation, teaching of skills, and practical problem solving within a consistent therapeutic relationship. We then have the occupational therapy pathway, OT. So OTs in mental health services work quite differently from OTs in physical health services, but together both areas build independence and look at skills, routines and confidence that people need for daily life and recovery by using meaningful activities to enhance well-being and independence, improving quality of life. And quality of life reduces risk. Next slide, please.
So what can people expect when they come into our service? Everyone who comes into our service, we start off with an extended assessment and formulation, which usually takes about 6 weeks. And then dependent on which pathway, whether it's DBT or SCM, we choose, has a slightly different entrance into. SCM, we would see someone moving into a socialization phase, which is 12 weeks long. DBT would have a pre-commitment phase, which is 6 weeks long. And then you move into the active treatment element, both of which for DBT and SCM is 6 months, but we repeat it because we find that the evidence base is that people start to embed the skills they've learned within the second run through. OT is bespoke and it can be as quick as 6 sessions or as long as a year. It really depends on the individual and what their needs are. And we can weave OT pathway into any part of our service. So someone might start SCM, for example, and then do OT. They might do an extended assessment formulation and need OT to be able to support them, to be able to get into groups. So it's quite a fluid pathway that we have. DBT, SCM and OT all have a group element and a one-to-one, and both occur weekly once in the active treatment phase. So it's a big commitment that we're expecting of any patients that come into our service. We also have psychology, and if accessing this after DBT or SCM, there are things like cognitive analytical therapy or PACT, because we love a good 3-letter acronym, and that lasts an average of 6 months. Our peer support workers, who are absolutely amazing, can fit into any part of our pathway. We may access peer support to really help people in those early stages of coming into the team, to think about what it's like coming into a new team. And our peer support workers will share their own experiences to help validate an individual and how they are feeling at the time. And then the other element is the DPD prescribing, which is also available throughout an individual's PACT journey. All of these are supported with telephone coaching. So telephone coaching works slightly different to duty systems in other teams, but it's where the practitioner and the patient work together to problem solve and empower the use of the skills and self-management, so enabling the skills to be used in daily life. Once we finish the active treatment, we move into a 6-month follow-up phase at the end of each pathway to help consolidate the skills that have been learned and transition out of the services. And we talk about that from day one. So when someone comes into our service, they know they are going to be with us, but will be discharged at the end of it. So there's real clear boundary to the work that we undertake. And our aim is at the point of discharge that the individual no longer requires the support of secondary mental health services, and they are able to go on and live a life worth living in their communities. So let's hear about how Elizabeth got on whilst working with PACT on the next slide, please.
So here we have Elizabeth again. She's 26 years of age now. She's working part-time in Waterbricks bookshop. She enjoys hiking on a weekend. She attends a nightlight cafe on a regular basis, where she's able to access support for herself and helping others by sharing some of her own experiences of being in mental health services and recovery. Her medication is managed now by her GP, and she no longer requires a consultant to oversee this. Elizabeth accessed PACT to help her understand her emotions better, recognising when she has unhelpful thoughts and urges. The interventions have empowered her to reach her goals she once never thought was possible. She sometimes still feels intense emotions and can manage the impact of this whilst living a life that is meaningful to her. Next slide, please.
So, due to the intervention nature and length of our pathway, we work with those with the most severe need or high risk to self that is pervasive, problematic and persistent throughout their life course. However, we do offer support and advice and guidance to other services wherever possible. Next slide, please.
So what is on the horizon for PACT? We do recognise that we work with a very specialised group of people. And at the same time, we want to support more people in our communities with a focus on survival strategies and difficulties in managing emotions. This will see us working closely with the Recovery College, building a programme that anyone can access to help with understanding these topics, whether experiencing them yourself or supporting somebody who experienced these difficulties. We hope to have this up and running by the end of the year, if not sooner. We're also working closely with the LMHTs to deliver RAISE, which stands for Relationship and Emotional Skills Groups. These offer a less intensive intervention than DBT or SCM, but on the same principles. We are working hard to understand our communities better and considering how we can best support more people and services outside of LPFT. Next slide, please.
Oh, thank you for your time today. It felt like a very whistle-stop tour of us in PACT. We hope you've enjoyed hearing about our team, and if there's any questions, we're happy to answer if we can.
Brilliant. Thank you so much, Ellen Jude. Really, really great presentation, really informative, but also quite impactful. And I think, you know, one of the things that stands out for me is how much you guys put into your approach and the thought and consideration that you put into supporting people in a really different way. So, you know, really great to hear all of that. Has anybody got any questions? Or any thoughts or reflections on anything that people have heard?
I just think it sounds a great service, really, and really kind of trauma informed with that engagement at the beginning to kind of get them into service and being accepting that it's not easy for them. Yeah, I just think that sounds really good.
Thank you.
Thank you.
I guess one of the things I was just pondering as I was listening to you both was, with you describing, obviously, you know, supporting people at quite high acuity and sort of, you know, quite long programs of support. I guess I was just thinking about when people are stepped out of services and, you know, do they need to access back in? Do you know what I mean? I just kind of thinking about how people may come in and out of services. And yeah, just wondered how all of that works.
We've not had many who needed to come back, to be fair, if they've managed to stay with us for the full length. What we have had is that it's not been the right time for some people. So we've started the process, and for whatever reason, it isn't the right time for them to engage with the service. So what we tend to do then is discharge from our service, but have a self-referral back into us within 6 months. And we have had uptake on that. We say within 6 months because I think that mirrors the boundaries that we hold within PACT. People can absolutely be re-referred further than 6 months, but we ask that it's the CPN or another professional who does that after 6 months. And the uptake when people have come back on the majority of the time has proved to be really positive, and they've been able to re-engage with what we've been doing.
I think it's really important to keep that door open for those 6 months. It's really scary coming into into services.
Sorry, Jude's logged herself out. She's in the room with me behind me, so she's just going to rejoin.
Don't worry, she probably does what I often do
Sorry.
when I stop sharing something, I accidentally leave.
Yeah, it's the
instead.
It's the microphone. Sorry.
Don't worry.
Yeah, so I think it is. People have often had difficulties getting into services. So I think it's really understandable that there's going to be some anxieties, some, survival strategies to keep feeling safe. So kind of maybe what we might term pushing away, or it might be, but actually it's a way of keeping safe. We ask a lot of people. We ask people to share some real difficulties that they've experienced in their lives. So building up those trusts takes time, and sometimes it just isn't the right time for people. So I think having that door left open for 6 months just gives people a bit of reassurance that we're not rejecting them. We're giving them some power and control back in their lives to walk back in the door, if that feels okay for them later down the line. And I think I don't think we can ever say people will leave PACT and never. We're human beings. We never know how we're going to feel. We're all walking, a kind of a tightrope through life, aren't we, with how we feel. But I guess what we hope to do is give people enough skills and confidence to be able to feel that they can problem solve things that come along. And problem solving might be to go to their GP or to access MUAC as a coping strategy.
Yeah, absolutely. And I think it's something we're, again, trying to enhance across the whole programme and across the wider locality mental health teams, aren't we, in terms of, some of people's fears or anxiety about stepping out of services are about how difficult it might be to get back into them, or that not being able to seek the right help when it's needed. So there's lots of work that's happening around trying to change that and make that feel a bit more fluid for people. Another bit that I just was pondering as well was, obviously, I know you talked about all of the work that you're doing in terms of that really integrated offer with the RAISE programme, and then the work that you're planning and working on with the Recovery College. I just wondered if it's worth as well talking a bit about the work that you're doing with the Lived Experience Reference Group, and the kind of comms materials that you've been working on with GP colleagues, just as that kind of wider, because I guess we understand at the moment that there might be people presenting with lots of different presentations of challenges that might be associated with personality difficulties in lots of different parts of our organisations, our system, and it's just understanding all of those different bits that you're doing to support the wider workforce.
Yeah, absolutely. I guess our reference group has been something that has been prominent from day one of our development. So anything that we produce or do with PACT has been sort of co-produced with our reference group over the last 5 years. We even down to just changing one word on a leaflet just changes what that leaflet can mean to someone. So we've developed our own leaflets about our service. But yes, most recently we've been working with a couple of local GPs as well to think about how to support people much more widely than what us as an individual team can do. We're still in the process of getting the leaflet finalised and signed off and things, but we produced a leaflet about emotions and understanding emotions, and that emotions aren't bad, and lots of our patients in particular feel they are, but our emotions tell us something, and it's about understanding whether what they're telling us and then what thoughts and urges are created from our emotions, whether that's warranted and whether that's helpful for us as individuals. And absolutely, there'll be some times where we do jump out of aeroplanes, not myself, but there are some of us that jump out of aeroplanes with a parachute. And if we listen to the fear, we would never do those sorts of things. There's lots of things that we do impulsively that are positive, and then there are some things that we do impulsively that are unhelpful for us as individuals. So I think over the last 5 years, we've really built that strong foundation of what we deliver within our team. And we really are at the point where we're thinking, right, what's next? What else is there out there in the community that we can really help and support with? At the beginning, I said, we've not got the magic, potion, and we haven't got all the answers, but we're absolutely willing to try and understand and support where we can.
Yeah, thanks, Ellen. And I think, again, what was going through my head a little bit when you were saying that as well is, just thinking back to Elizabeth's story as well, and some of all of the work that we're doing around those community spaces. I know Elizabeth goes to the Nightlight Cafe regularly now, but I guess what we are aware as well is there will be lots of different people who are presenting in all of our different community spaces, our wellbeing hubs, in the different activities. And again, perhaps some of that work that you've been looking at with primary care, we can think about how some of that might support some of the workforce and the people that are in those hubs as well, to for people who might be presenting having some really difficult times as well.
Yeah, I think it's really important that there's a lot of stigma around the diagnosis of people with personality difficulties, and I think just giving people confidence and a bit of understanding around what's going on for people is huge. It can be really helpful and make such a difference to people's responses and relationships that they're able to build. Because again, as Al's just spoken about, our emotions, we're all emotional beings and we all have emotional responses to things. So if we do feel fear, it's not abnormal to feel it, but it's how that manifests itself.
Yeah.
And that can be the difference between someone's experience of walking in the door and feeling comfortable and the person feeling confident about being able to welcome that person in and support them. So yeah, if there are things that we can help with in those, just kind of general understandings, then that's an avenue that we're really happy to go down as well.
Yeah, I think so. And fear was the word I picked up when you first started talking about Elizabeth's story as well. And, and I think thinking about how perhaps people feel worried about saying the wrong thing or saying things that might make somebody feel worse, or, really having an impact on somebody in a way that isn't helpful to them. And it's that sort of stuff, I think, isn't it, that we can find a way to support around.
Absolutely.
Brilliant. I'm just double checking if there's any questions. I think there may be. Having a little look. I've got just a question in the chat around, do you do DBT as a group as well as individual delivery?
So DBT, in our pathway, we do the full DBT program. So it is a group and a one-to-one individual session each week. We don't deliver it on an individual session. So it is a full, you do both.
Thanks, Elle. I think my internet might have just kicked in. A whole load of questions have just dropped into my chat that everybody might have already been able to see. Just a comment from Marie Kay saying, really great to hear about the service. Really informative and useful to know the service is available. I've got a question about referral criteria.
So we accept referrals from the locality mental health teams, or community mental health teams as they were previously known as. We don't accept referrals direct from any other source, and that is so that the initial assessment that's undertaken within the community mental health or locality mental health teams now ensures that the right pathway is being sought for the best for that person's needs. So we would be a pathway that is referred on to from the community mental health teams.
So I guess if somebody was supporting somebody under different services that they believed may be struggling with personality difficulties, then it would be go to see your GP and be referred via the locality mental health team.
Yes. Yeah. And then I guess what we would look at is, because we work with the severe side of personality difficulties, unfortunately it does come down to things like self-harming levels and the impact. So we would work with the people directly who are having the most severe impact on their day-to-day lives. The raise that we mentioned, that would be for people whose the next sort of level down from that. And then if there are people who don't necessarily meet the criteria for secondary mental health, the course that we're designing that will be available in the Recovery College will be available for every single person within Lincolnshire should they wish to access it. So our hope is by the end of this year, we should have something for everybody's needs.
Brilliant. Thanks, Elle. Another question, does anyone that already has a psychiatrist consultant involved be offered this? So if somebody is already under a consultant psychiatrist, I guess as part of their locality mental health team offer, I think that's what's meant by that question. Is that something that will also be considered?
Absolutely. Quick answer to that one.
Great. Another question. Well, I think it's a question, or maybe my son has a diagnosis of EUPD, just from an acronym perspective, so emotionally unstable personality disorder. He could have benefited from this service, but unfortunately is not interested in engaging with any services. Is there any advice or thoughts from either of yourself regarding that?
I don't think it's uncommon. I think sadly people do struggle to seek help. It's a difficult one. I suppose it's drip feeding things in and offering reassurance really that there are services out there that are, and interventions out there, certainly by the end of the year, that could be helpful to kind of look at first, say potentially. Again, not everybody, the Recovery College is not for everybody, but I suppose it's a way of dipping your toe in and seeing what's kind of going on. Yeah, it's difficult, and unfortunately we don't offer like an assertive outreach approach. It's very much us. We will work hard to keep people to support people to come into the service, but they have to have been, they have to be in a place like within secondary mental health services before we can begin to do that. So I'm sorry, no, probably unhelpful answer really.
I suppose, like you say, Jude, it's just as much as possible, and again, it's still still may be very difficult because there may be things that people do or do not wish to engage with. But I suppose it's about us trying to make as broad an offer as we can across all of that kind of continuum of care, isn't it? So from the community to the, you know, the interventions that you deliver. So we're offering a potential way in for people as a, you know, like you say, that kind of stepped approach, really.
Yeah, and it is really difficult, you know, when your family members, when you see them suffering, but it's also really understandable for people who experience difficulties with emotions, that to walk into services and start to build those relationships with providers as well. So I can see both sides of it. It is a difficult situation.
Absolutely. Presumably your service is available to autistic individuals with personality difficulties?
Absolutely. Another quick answer, yes. We will make adaptations as required.
Brilliant, thank you. Another comment from somebody, I know how effectively you use peer support in your team. It doesn't surprise me at all that Martha helped to co-produce these slides. It would be good perhaps to showcase how you utilise your peer support with wider community teams, as it's highly effective.
Couldn't agree more. Martha's amazing, as is Laura. They're absolutely incredible, and they do a marvelous job, and they're such a bridge in building those relationships between the professionals, who might seem quite scary, hopefully not, but you know, that kind of building that trust from and giving hope to people that things can be different. Yeah, they're incredible. Absolutely agreed.
Yeah. And we do have peer support workers across the locality mental health teams, and I think absolutely we hear very similar feedback across all of our teams, really, about the amazing jobs that the peer support workers are doing. What is the general waiting time after referral, please?
Within 4 weeks. Again, so it's a short answer. So
is that from the locality mental health team into your service?
No.
Is that the, or from
so
the...
once we've sorry, Jude, can you just mute?
Sorry,
I hate hearing my own voice back because it feels like I put on a fake Welsh accent, so I needed you just to mute then.
She's a Cockney, really.
No, so once somebody's already in the CMHT and the CMHT have made their referral into us, then we would see someone within 4 weeks.
Brilliant. That's great. Thanks, Elle. I'm very grateful somebody's put in the Recovery College link. I'm not very good at multitasking, so I'd have gladly done that, but it would have had to be following the webinar.
Can I just point out that the course isn't on there yet, although there is a course on there, understanding EUPD? EUPD, yeah. So there is a course on there. I mean, they're amazing and they do some brilliant courses. So it doesn't need to be ours. There's something for everybody on there, and I'd highly recommend having a look at the Recovery College courses.
Absolutely. Martha's just added it onto the chat. Thanks, Martha. Brilliant. I think that's, I'm just double checking because we've got 2 question and answers sections. So I'm just making sure I'm not missing anything that anybody's posted, and then just checking there's not anybody who's waiting just to ask or feed anything in. No, that looks like we've probably captured everything. Thank you, Elle and Jude. Thank you so much for your time to come and talk to us today. And thank you ever so much, everybody who has joined us. Oh, a question has just popped in, sorry. Are people with drug and alcohol addiction able to access services?
I'm going to repeat myself, but absolutely. Yes, we work really closely with Lincolnshire Recovery Partnership, and that's not a criteria that would rule someone out from working with our service.
Wonderful. Thanks, Elle. Brilliant. Okay. So thanks again, Elle and Jude. I'll say it again, but thank you so much, everybody, for joining us. Really appreciate the time that people take out to be here with us on the webinar. Oh, Nicole, did you want to just come in with a question? Oh, I think probably not. I think it may have just been appreciation for a really great webinar. So thank you, Jude and Elle. We haven't actually got any other webinars planned at the moment. So this is the end of our latest phase of webinars, but obviously we will be in touch with people if we do have any in the future, and we'll keep in touch with people about any other comms or pieces of work that's going on within the transformation programme. Thanks ever so much, everybody. Hope you all have a lovely afternoon, and take care. Bye-bye.
Thank you.
Thank you.
Thanks a
Bye.
lot. Bye.